Okay. Good afternoon and welcome to the Health Overview and Scrutiny panel. I'm Councillor Mark Jeffrey, Chair of the panel. So, first of all, some housekeeping information, safety information. If the continuous fire alarm sounds, please evacuate the room and public gallery as well, and go down the stairwells. Do not attempt to use the lifts. Please assemble at Queen Victoria's statue in the Guildhall Square. In order to comply with the Guildhall Trust Fire Marshal regulations, anyone who signed in at the Guildhall reception desk should sign out when leaving the building at the end of today's meeting, not during a fire alarm. Yes, yeah. Live web streaming. So may I draw everyone's attention to the fact that this meeting will be live streamed. Everyone speaking via microphone will be on camera. Members of the press and public are also permitted to record the meeting on the understanding that neither it disrupts the meeting nor records those stating explicitly that they do not wish to be recorded. So please can everyone use the microphones and remember to switch them off when they have finished. So could we give introductions around the table? So starting from my left, if you could say your name and what council you represent, please.
Hello, I'm Gillian Harris from Havant Borough Council. Thank you.
Lee Tyndall, Councillor for Copner.
Councillor Spencer Gardner, Portsmouth City Council. And just to give my apology in advance, I can only stay today for an hour. I've got a 3-day-old baby at home, so I need to dash back. But I wanted to come, especially because it's my first meeting of this type. So apologies for that, Chair, and also apologies to the speakers.
Councillor Jonathan Williams from Winchester City Council.
And your substitute for Councillor Atwell, isn't it?
Yes, Councillor Atwell sent apologies, yeah.
Councillor Graham Heaney from Portsmouth City Council and Vice Chair of the panel.
Lisa Gallagher from Democratic Services.
And we are expecting Councillor Gerald Vernon-Jackson from Portsmouth City Council, so he'll join us shortly. So thank you for your introductions, everyone. Just to let everyone know here, members have read the reports, so presenters, please just highlight any developments that have occurred since the publication, and we'll then ask any questions that we might have as well. So we've had apologies received from Councillor Oliver, Councillor David Evans, Councillor Vivian Ashwell, and I just need to ask if anyone, if there's any declarations of interest here today. Councillor Williams.
Yes, my employer is a consultant orthopaedic surgeon at QA.
Thank you. Okay, did you get that? Could you repeat that?
Yes, sorry, my employer is a consultant orthopaedic surgeon at Queen Alexandra. Okay.
Welcome, Councillor Vernon-Jackson.
My apologies for being late, and I don't have any interest to declare.
Okay. So next on to agenda item 3, which is minutes of the previous meeting. So what I'll do is go through our page numbers, and if anyone has any corrections, if you could indicate, please. So page 3, page 4, page 5.
Just a question on. Oh, sorry, I've got the wrong page 5. There's big page 5, and so I'm sorry.
Okay.
No,
don't worry.
So it's page 7, isn't it? I want to.
Yeah. Page 6. Page 7. Councillor Heaney.
Right, correct page this time. At the 4th paragraph, there was a point at the end which said the panel asked the ICB to write to the leader of the chief executive piece to give an indication of progress and come back on to a future HOS meeting with an update about the stroke recovery service. Have we had anything from them? Do we know? I mean, I know this was back in March. Was it March? March, yes. Do we know if we've had anything? I mean, if we haven't got an answer, if someone could maybe get back to me or let us know.
Yeah, I don't know the update, but I think what we should do is, could we ask Andy Biddle at the end of his report if he knows?
Oh, okay.
That'd be okay? Or do you want to say now?
Sorry, we were wittering. Beg your pardon, Graham. You'll have to ask your question again.
I was just referring to paragraph 4 on page 7. At the end of it, the sentence says, we're talking about stroke recovery service, the panel asked that the ICB write to the leader and chief executive of PCC to give an indication of progress and come back to a future HOS meeting with an update. I just wondered if we'd had anything, because it was March, and I don't know if there's a hand being waved.
Yeah, sorry, happy to respond. I'm speaking later. James Rose, Director of Primary Care. That report will be ready in September, so it will follow in September.
Okay.
And I believe Andy Biddle's having some conversations with David Bailey in the interim in terms of the information that's required.
Okay.
Yeah, you will be reaching out, but the report will come in September, because I believe you asked for an ICB-specific position in terms of their financial position, not a wider system one. So I think the aim is to make that report a bit more specific, but there is a commitment to bring it back into the September meeting. And I'll stress the urgency when I get back as well, and make sure that you're linked in.
Thanks.
As the husband of
Councillor
somebody
Jackson.
in QA suffering from a stroke, I have to say the stroke the stroke pathway is not evident.
Okay.
In that he's been a month on a respiratory ward, you have no idea how to deal with brain injuries.
I don't think we're supposed to talk about individual cases here.
Sorry.
Okay, thanks. Okay, so moving on then. So page 8, any corrections for page 8, please? Page 9? And page 10? Okay, so does anyone propose to agree these minutes? Councillor Heaney, thank you very much. And a seconder? I was there. Can I second it? I'll second the minutes then. Thank you. Great, thank you. Okay, so moving on to agenda item 4, which is adult social care update. So over to Andy Biddle, please. Andy, could you give us a brief summary of your report, and then members will ask you questions. Thank you.
Thank you, Chair. So firstly, my thanks to all of my colleagues that were involved in contributing to the report, and particularly to Debbie Young and Katie Downer for drafting it. The report is a lengthy one, for which initially my apologies, but it covers 6 months' worth of activity in adult social care, and so we've tried to section it up so it's a bit more readable. Based on previous discussions with HOS, we've also tried to reflect the outcomes for our residents from all of the work that we've detailed in the report, along with some of the information the panel may find helpful. We've talked about preparation for inspection, which is a very significant part of the work for adult social care currently. Will be inspected by the Care Quality Commission at some stage, and there's more detail on that particular piece of work under section 9 of the report. The report highlights changes in the NHS locally under sections 4 and 5. Some of the grant funding for adult social care that we've seen in the last 12 months is set out in section 6, particularly with some aspirations around how we hope to use that to support our shared lives service and our informal carers in Portsmouth. Some of the work of our occupational therapy service is set out in section 6, and the changes to our hospital discharge and rehabilitation services are also set out there. Changes being made to help more residents benefit from the support that we can offer them. Section 6 also sets out how support is developing for our residents with a learning disability and the work of the mental health hub in the city. Also in section 6, the report shows feedback from residents to our carers service and the number of projects around helping residents maintain their independence and well-being, preventing the need for formal care and support, which is one of our statutory duties under the Care Act. There's information regarding engagement with our residents and the work to develop something called strength-based practice in Portsmouth adult social care. The report shows how our in-house services, care home, respite and shared lives are developing. In section 7, information is included around the residents we're supporting through residential and domiciliary care in the city and the trends in those types of support. And that section also sets out how we're working with deprivation of liberty safeguards and some of the challenges in assessment under the Mental Health Act. The report also gives information around safeguarding and complaints. In section 8, we've set out a summary of the adult social care strategies and included the strategy and plan on a page. And we've also talked of other strategies being brought forward this year around carers, autism, accommodation and finances. Section 9 gives more detail around the inspection of social care, very prescient subject at the moment, and sets out the latest ICB response to support for those residents who've experienced a stroke in Portsmouth, but obviously that will be updated by the report that will come back in September. And that Section 9 also details work around modern slavery and quality assurance in adult social care. Finally, Section 10 gives brief information around our governance structure, and Section 11 some of the work with the social care provider market in Portsmouth. And the appendices give some more detail around community connectors, strength-based working, the 23-24 complaints report, which we've recently published, and data around equality, diversity and inclusion from the work of the independence and wellbeing team. That's a brief summary. Happy to take any questions.
Thank you. So, members, do you have any comments or questions, please? Councillor Heaney?
I've had a couple of questions. They're more specific detail ones, really, rather than general commentary. I noticed on paragraph 6.9, in the third paragraph, you talk about data, quality of data, and you say we're making full submissions. Well, we're making full submissions. The limitation of our client recording database significantly impacts our ability to introduce support mechanisms for staff when they record information. Is there anything that can be done to improve the information system? Because this must be the bane of people's lives if an information system doesn't work properly. Can we do it, and can we do it without significant cost or extra problems?
It's a good question. I think there's always a compromise with information systems. So the system that we use, System 1, enables ourselves and our primary care colleagues, GPs, to be able to see the same information. It also enables colleagues in Solent NHS Trust to see that information. The issue is that it's a system originally designed for the NHS, and so it's not designed with the work of social care in mind, and so extraction of data is more difficult than if there was a specific social care system in place in Portsmouth. So it's a compromise, I think. We are trying to make the lives of our staff slightly easier by the way that we extract data, and we've got a project going on at the moment that, in very basic terms, lifts data out of the system and puts it into a format that we can then use to send back nationally. We are also, probably by the end of this calendar year, going to be looking at all of those systems available on the market currently, because the contract that we currently have for System 1 comes to an end. I wouldn't like to say that we won't renew with System 1, but it would be entirely sensible of us to see if there's something that will better serve ourselves and our residents. So a bit of a compromise, and we may see some changes, although I wouldn't necessarily guarantee that by the end of the year.
Councillor Heaney, did you have a follow-up question?
I have a second question, which is on a completely different aspect of the report, which we now go to page 38, 39, paragraphs 11. It's about care homes and market sustainability and quality. It's obviously good to see that the quality of care or the inspections is getting better. I mean, it's good. What I wasn't quite clear of, and I don't know whether I misread it, I did read it quite last night, but I couldn't work out whether we've either lost places, a number of places we can give people, or whether we've kept them at the same, or whether we've got more. Quality is obviously one aspect, but can you enlighten us as to whether we're gaining, sustaining, or losing places that we can give people access to?
So we experienced, probably thinking about it, it would have been coming toward the end of 2022 and the beginning of 2023 as a calendar year. We experienced 5 providers withdraw from the market in Portsmouth, 5 care home providers. 2 of those providers weren't providing quality care, and the Care Quality Commission closed them, and we supported people to relocate and find new places to live. But 3 of those withdrew for individual reasons, but I would say broadly financial. In a couple of cases, the use of the buildings and the land, it was more financially advantageous for them to stop being a care home and have other uses for that. So that squeezed our available capacity in Portsmouth in the independent sector. As it stands at the moment, in very broad percentages, there's roughly 4% of care home placements are unavailable at any one time. That might be through shared rooms, that might be staffing, might be any number of reasons. And the purchased care home places in the city are about 92-93%, so there's a very skinny margin, if you like, of capacity that's left in the independent sector in the city. That does mean that we sometimes have to place people outside of the city when they need residential care. One of the mitigations against that is trying to ensure that everyone who can and needs to can have reablement, can maintain independence, can have an alternative to care homes. For instance, either care in their own home or extra care, where they've got their own front door but care on site. We are in discussion at the moment with a couple of companies around whether there are opportunities to build care homes in the city. It's a particularly difficult financial model in recent years, so those are very, very early discussions at the moment, but we are concerned about the capacity we have in the city. Ideally, if somebody does need a care home, we would never want to place them outside the city unless that was their choice to be with family or whatever that was. So there is at the moment a squeeze on our capacity, and it's difficult.
Thank you. Are there any follow-ups on this particular issue? No. Okay, so Councillor Raffaelli, you're next.
Thank you. Hello, Andy. I last sat on this committee in 2021, and it's perhaps not surprising that the main topics are all exactly the same, but there was 3 areas that I just wanted to pick up on. The first one was on System 1, and you are now looking, because you talked about that a couple of years ago, so there were these challenges you described. But on 6.3 and 7.3, with respect to detox, the delayed transfers of care, I get the impression from reading that, although there's no data, that it's still a severe challenge to you and inevitably for hospital and in and out. What I was surprised about was that the Discharge to Assess programme, which 3 years ago was really seen as being one of the ways of getting to grips with that, is being discontinued. So on that one, can you comment a little bit on detox and where it is and what's happened to Discharge to Assess and what's taken its place, if that's all right, Chair?
So in terms of detox, I think it will always be a challenge because we don't have the perfect system to help someone come out of hospital when they need to, and we also don't have the perfect systems for preventing people being admitted when they don't need to, and so we'll always see quite a significant number of people in our hospitals. I think we've got better at it. In Portsmouth, we reorganised our social work support at the beginning of this year, so that we had a single team that was focused on all of the areas related to discharge, so whether that be a bed in the community that was run by the NHS, or it be a bed that was jointly run between us and the NHS, or indeed someone coming out of acute hospital, or someone needing reablement in the community. And so we saw a downward trend in those numbers of people that were delayed in hospital. And we also saw a downward trend in the numbers of lost bed days, so the amount of time that someone's delayed in hospital. But I think detox will always be a challenge. I think we are coming into, I'm not being flippant when I say this, but we will soon be coming into what feels like an NHS winter, and that tends to start sort of mid-August toward beginning of September. Yeah. And there'll be additional pressure put on systems because of that period of time in the year. We do have a lot of joint resources in Portsmouth. We operate reablement beds between ourselves and Solent NHS Trust. We've got some work to do to reduce the length of stay that people stay in those beds there in the community, so that we have a smoother flow of people coming out of the acute hospital that need those beds. So that is work we need to actively do. We also have an agreement with our colleagues in the Integrated Care Board in Hampshire and the Isle of Wight that we purchase extra domiciliary care for those people that are needing to come out of hospital. So we do have some schemes in mitigation. The Discharge to Assess scheme was strongly related to the 2 major waves of the COVID pandemic. It occupied a lot of NHS resources, and we saw that pretty much come to an end for residential care last calendar year, around about September. And then in April of this year, the beginning of the financial year, that ended. That was a decision around investment. There was a lot of money being spent in the Hampshire and the Isle of Wight on Discharge to Assess. And I think the feeling was there was clearly a financial squeeze on budgets for the NHS. And there was a feeling that that wasn't necessarily the best use of the money. So we don't have a Discharge to Assess formal scheme at the moment. There is an upside to that, though, as well, in that people were coming out and being placed in care homes, but there wasn't necessarily the support around to then get them out of the care homes the other end if they could go back home. And so we've seen a slight decrease in the numbers of people coming out of hospital and going straight into care homes, which is right for the individual. But it is a difficulty because there's clearly a chunk of money that now isn't in the system.
Thank you for that. I presume the second one.
Yeah, what would be the way I like to do it, if possible?
A quick follow-up that one, yeah.
No, if people have a follow-up on even if it's more than one on this issue, let me know, and I think that's the best way to do it. So, yeah.
I've got a comment or a question, and I think I know the answer, is that the actual data for detox and for medically fit for discharge will be presented by QA or the ICB or both indeed, rather than from your end in due course.
Yes, it tends to be because that data is generated through QA. Yeah.
Any more follow-ups on this particular issue? Okay, so would you like to ask your other question as well?
Yes, please. On 7.3, the deprivation of liberty, that had only just begun to come in 2021, and it was perceived at that time it was going to be a huge piece of work. But the confidence at that point was that by 22, 23, and I know things have happened in the interim, don't get me wrong, it's still a massive drain on your resources there, and you're talking about 2025 or so now before it's addressed. Is that just because of the volume and the complexities, or have there been issues?
I mean, it's been really difficult because deprivation of liberty is better than nothing, because it is ensuring there's a proper process before someone is deprived of their liberty, and that's lawfully compliant and as it should be in terms of human rights. But it's been acknowledged that it's cumbersome, it's taking too long, and there are many local authorities who have a very significant backlog of assessments, so it's not serving people well. We're incredibly fortunate in Portsmouth, both in terms of the quality of the colleagues that are here who work in working through deprivation of liberty agreements, but also that we manage our backlogs fairly well, so it's not such a major problem in Portsmouth. The replacement for it, the Liberty Protection Safeguards, LPS, were due to be brought in originally in 2023, if my memory serves, but they got delayed a few times, and they were then finally parked at the almost at the end of 2023. And what the Department of Health and Social Care was saying is there wasn't the capacity. They were focusing their capacity on other things. So LPS was intended to be more efficient and effective than the DOLS process. So we have DOLS at the moment. We anticipate 25 we might see LPS, but we haven't had any confirmation of that yet. It wasn't in the King's speech yesterday, although Mental Health Act reform was in the King's speech yesterday, which is something else that's been waiting for a while. So until we see liberty protection safeguards, the code of practice, the training and all that sort of thing, then we'll be working with DOLS and we'll have the same issues I think that we've had for some time.
Thank you. Are there any more comments or questions on this issue at all before we go to the next question? No? Okay. So next I've got Councillor Vernon Jackson.
Andy, can I ask, in terms of domiciliary care, a while ago, if my memory is right, we did a piece of work to look at doing things differently, where instead of booking 15-minute slots or 30-minute slots or whatever, there was a piece of work to just do the amount of time people wanted and needed, and that seemed to reduce the amount of time that people spent on site, but it was the time that people wanted. Have we gone any further with that? And the reporting of that seemed to go very well in terms of filling in form on people's phones from the carer, which then immediately went to social care, the agency, but also to the family, so that they knew the support that had been given.
So the pilot did work very well, and we had some really positive. You're right, we had some really positive engagement with families, particularly those that were, were based abroad. When it came to it, to implement a system across all of our care providers, we couldn't. They'd all purchased their own systems in the interim, and the costs would have been exorbitant to have a single system working across all the providers. What we have done is we've done some some latitude, I guess, some latitude in terms of individual agency. So if they're saying to us, well, actually, Mrs. Smith, for example, needs some extra time today, or she doesn't need that as much time as she had, then we're enabling them to make those arrangements with her because they know Mrs. Smith far better than we will. The carer has been working with her for much longer. So that's as far as we've got with that. It was, unfortunately, there was a cost issue about a single system.
Are there any more follow-ups on this particular issue at all? No? Okay. Any other... Oh, did you have a follow-up on this one or another question?
I have a different question.
That's okay then, you can go next.
Thanks. So, traditionally, the feedback I've had from clinicians and people working in the NHS was that the system of integration between health and social care in Portsmouth was very good, and that Portsmouth residents tended to get out of hospital quicker than Hampshire residents. But we were then pushed into Hampshire and Isle of Wight ICB, where performance was less good, and the hope was that performance in the rest of Hampshire would come up to the Portsmouth standard and not the other way around. And the Portsmouth PCT was financial, always came in with a, I think came in below budget. My feedback I now get is that Hampshire and Isle of Wight ICB is in financial problems, and that the integration between health and social care for Portsmouth residents is now no longer as good, and things are getting worse, and we're being pulled down to a Hampshire standard. Where are we, and what's the feedback here, and what should we be doing? Because we had a system that worked, which was then junked.
I suppose I would say this. It's complicated. I think
many of us are.
Yes, yes, indeed. So I think what we've seen is a change in the way that we work together. If we take it at a commissioning level from the Integrated Care Board perspective, we have met recently with senior colleagues in the Integrated Care Board, and we are improving on what was a temporary memorandum of understanding in the way that we work together, in the way that we commission together. So I'm hopeful that will start to manage some of the conflicts that we've had in the past 12 months, if I'm being honest about that. I think the piece that is still very solid and does benefit our residents is the work with Solent as an NHS trust, so our learning disability team, our mental health team, our reablement team, all work together, and our delayed transfers of care and transfer of care hub is multi-agency, and those are still very much integrated team. They still get really good results for people, and we see far less of people being pushed from pillar to post, having to tell their story twice, those kind of things. I think we've got a lot of work to do between ourselves and the ICB to rebuild some of those integrated relationships, but I think what I'm hearing certainly in the past couple of months is a real commitment to do that. So I'm more hopeful than I've been for a while.
Okay, do you have a follow-up on this issue? Yeah, okay.
So I spoke to the previous Secretary of State about this on the basis of we were being pushed into something we didn't think was going to work when we had a system that did, and that if it didn't work, could we pull out to the ICB and go back to a system that worked for our residents in Portsmouth? I hear nothing from what you've said to give me confidence that things are better than they were under the previous system. Should we be formally pulling out of the ICB and re-establishing a local system on coterminous with our social services boundary, so that we could get that integration between health and social care, which is what the ICB is meant to do, but it doesn't appear as if they're able to?
I don't know if I can answer that question, to be honest. I think we are part of the integrated care system in Hampshire and the Isle of Wight, and we do work at a Hampshire and Isle of Wight level with ICB colleagues. I don't know that I can give you a cogent, intelligent answer to that, because I think it would be a really difficult thing to do. I mean, I speculate that we're seeing a review of the NHS. Lord Darcy's been asked to do a review of the NHS and report in September, so it's a fairly rapid review. And whether we'll see recommended changes from that, I don't know. I think it would be too glib of me to give a really straightforward answer because it's such a complicated issue. Sorry.
Okay, are there any more follow-ups on this particular issue at all with any members here? No. Okay, any more questions for Andy Biddle at all from members? No? Okay, thank you very much, Andy. So your report's noted. Thanks for you and your team's work on getting that comprehensive report together. I would say normally that you're welcome to go, but actually you're not. Because agenda item 5 is Portsmouth Safeguarding Adults Board resourcing Andy Biddle. So it's the same sort of format as we did then, and I know that you're aware. So Andy, could you give us a brief summary of your report, and then members will ask questions.
Thank you, Chair. So my thanks to Alison Lawrence, who's the Portsmouth Safeguarding Adult Board Manager, for drafting the report. And this report was agreed by David Goosey, who's the independent chair of the Portsmouth Safeguarding Adult Board. So Section 3 sets out the statutory context for the Safeguarding Adult Board in local authority areas. And Section 4 sets out the approach to resourcing the work of the Safeguarding Adult Board in Portsmouth for 23-24. Section 5 gives some more detail around the requirement for the 24-25 current financial year for the Safeguarding Adult Board, and Section 6, the concerns around the level of resourcing and the equity across Safeguarding Adult Boards in Hampshire and the Isle of Wight, because each local authority has a Safeguarding Adult Board is required to. Section 9 then sets out that information in tabular format, and Appendix 1 sets out more detail around expenditure and requirements. Since this report was written and submitted to HOSP, colleagues within the ICB have met with the Portsmouth Safeguarding Adult Board Independent Chair and acknowledging the significant variation in funding arrangements across Hampshire and the Isle of Wight. The ICB colleagues have committed to a meeting to bring together the board chairs, police, NHS and local authority leads to develop and agree a single methodology for funding. And for that to be informed by population size and levels of deprivation. This meeting is likely to take place in September. In realistic time frame, I don't think it's going to happen in August. So happy to take any questions, but the panel may wish to request an update to this report following that meeting.
Thank you, Andy. So first question I've got is from Councillor Heaney, please.
Well, Andy, I feel slightly sorry for you having to sort of respond to this report, and because I noted your comment that you said there was a meeting taking place, because quite honestly, utterly extraordinary that the ICB appear to have taken a decision to penalise Portsmouth directly in the way they do the funding. And I noted the report said that they provided no rationale for their decision. I mean, I understand that the ICB is in very severe financial difficulties, and you might have assumed that they would have taken the approach of maybe slicing a bit of everyone on the basis that that would be fairer, if not necessarily, you know, welcome or justified. But to go and do what they've done sounds absolutely extraordinary. And I'm glad they're going to do what you suggest, but I'm wondering, are we going to get this sorted in enough time to impact on the allocation for this year? Because we're now, in July, and we have a meeting in September, and we'll be well through the financial year before they actually work out what they're doing, which again I think is totally extraordinary. So I'm sorry to sort of land that at you, which I'm not obviously blaming you. I just wish some of the ICB here would come and account for this, because I think they're the ones responsible for this. So what do you think is going to happen? Can you enlighten me any further on that?
I think, so I can't necessarily speak for ICB colleagues, but I think we shared this report with them when we knew it was going to be published, because we wouldn't want them not to know that this was coming here. And I think that prompted that discussion, so that was helpful in and of itself. We've got at the moment the allocation for this year, which is indicated in the table, but obviously that's a very low allocation. So my anticipation would be, if we can come to an agreement in September, then we should be able to address the numbers for this financial year, because there is work, you're entirely right in what you're inferring, there is work the board needs to do in this financial year, and it's important work, and it's acknowledged by all of the partners as being useful and as strengthening the safeguards for our residents who are in need of safeguarding. So I would hope we have a bit of a retrospective application of whatever is agreed at that meeting. Obviously, I don't know what will be agreed, so I may be being overly optimistic, but that would be my hope.
Would you like to have any follow-up for this?
Come back on that. I mean, yes. I mean, I suppose the difficulty I see with this is that if they're going to come up with some sort of formula, for want of a better word, for the allocation, and then they apply that, it could mean that the other areas lose out and we gain, which of course is also not entirely helpful. I mean, I can understand that there may be some sort of a top-up arrangement, but again, it seems to me that the ICB should surely have approached this with a view of having a fair and transparent process for assessing what they were going to give, and they don't seem to have done it, and it again is pretty poor.
Councillor Raffaelli, I know you've got a comment.
Thank you. I think it's an extraordinary decision that they've made. And I think as a body, we can only say that this is just unacceptable. And we, of course, must ask for it to come back with an update after the meeting. I do have one specific question. It's on 6, it talks about reasons for recommendations, and that actually doesn't fit. Were you going to come out with a recommendation that was perhaps pulled at some point? Because I didn't understand what you meant by that, because there isn't a recommendation in the report, but section 6 is titled reasons for recommendations.
Bear with me, I'll just pull that up.
So page 67. Page 3 of your...
No, you're absolutely right, and my apologies, that's an error. So our recommendation would have been to ask this panel to make formal representation to the ICB.
On this issue, so it is unacceptable. So they're due to come back to the next meeting anyway, aren't they, Lisa? Yes. Yeah. Okay. So, in terms of the report, do we just want to? Should we say it's noted and we believe it's unacceptable? Do we need to vote on that, or?
No, Chairman, I think we need to write. We need to write to the ICB to say this is unacceptable and that they need to reconsider.
I mean, I think that would be a good thing, but in terms of the meeting, how do we need to?
We entrust you to write a stroppy letter.
Okay.
Can I suggest? I mean, I thought it said consider, and I obviously wanted to hear what other people said. So, I mean, I think what we could do is we could say that we do consider the decision of the ICB unacceptable in this respect, and we want to write to them to that effect, and ask them to come back to us with a further report on how they intend to address the financial inequality in the allocations. If that's a suitable way of...
Councillor Raffaelli.
We might just want to say that we were, however, slightly not letting them away with anything, but to note that we had some optimism. We were pleased to hear they were meeting to reconsider this, and we would hope that this results in.
I think that should be included as well, so we'll include that as well.
Sorry, can I just clarify? So, where they haven't provided a rationale for their funding, did they actually respond to our letter that we sent?
Andy.
We've had some difficulties in getting responses. I think it's fair to say that, being entirely transparent, the colleague that reached out to us most recently hasn't been part of that, and so wasn't aware, and so they were doing their very best to try and manage the situation appropriately. So we've had some difficulty in getting responses back.
Councillor Vernon-Jackson, were you looking to speak on this
Only
issue?
to say that we should send a stroppy letter.
Hi, did you want to speak? Yeah. I think that's really helpful. I'll still write anyway and share a draft with the members. Thank you. So we note that report, but also think it's unacceptable. Are we allowed to say that in the minutes? and an action will be that I'll write to the ICB. So, Andy, thanks for giving that report, and you are welcome to stay, of course, but equally, if you need to go, go.
Thank you, Chair. My Mrs. Biddle has other plans.
So the next agenda item is 6, South Central Ambulance Service. So Tracy Redmond, would you like to come forward and sit at the desk there? Okay, and when you want to speak, just use the button on the right. So Tracy, could you give us a brief summary of your report, and then members will ask questions. Thank you.
Thank you, Chair. Thank you, everybody. Just in terms of the report, obviously I take as read, but I'll give some highlights. I think it's worth highlighting that the work between SCAS and partner providers, both health and social care, continue to build and grow, all of which is of benefit to the patient. That's both externally in the community, but as well as in our control room environment. Obviously, our ideal aim is that people are treated in the most appropriate place, and if that can be in their home and that's their wishes, then that's what we try to do. We've got some work ongoing around looking at having a single point of access in terms of being able to dial into a centre and then have a clinical discussion with some senior clinicians from partner agencies to help those conversations about where best to take the patient or where best the patient could be looked after. So that's a work in progress as well, and that's a Hampshire and Isle of Wight project in its early development, but SCAS are a part of that as well. In terms of new developments, SCAS in April of this year transformed across in terms of patient safety to the NHS Patient Safety Incident Reporting Framework. So this is an NHS-wide programme which some folk may already be aware of, but SCAS have been in a process of transitioning to this programme over a number of months and went live in April. And this moves us away from a culture of blame into a culture of learning, and the point of this framework is around identifying learning opportunities to prevent avoidable harm. So that's new in SCAS over the last couple of months. Some significant work's gone into it, and it's very exciting because it really is patient-focused. Certainly part of the process is around including the patients and their families in some of these reviews where it's appropriate, to make sure that everybody's involved, to make sure that all the learning is captured. And within that, there's also the process for learning and sharing across the ICB and across other partners as well. So whilst we had processes in place previously, we're now up to date in terms of how the NHS is working, and it's a much better system for us to learn to prevent future mistakes. So some positive stuff there, which is work ongoing. In terms of demand, I know I've brought you these charts before, and they still look the same as they always did. However, demand does continue in the southeast. For SCAS, you can see on the first chart there the comparison between last year and this year. The profile is generally the same because it's fairly seasonal, but the numbers clearly are growing year on year, as is the acuity of the patients. Again, in this area, SCAS respond to more Category 1 and 2 calls than it does in any other areas of SCAS. And I think that is partly because our community services are so good and they look after some very poorly patients in the community. So when SCAS does get the call, it's further down their journey because they're already being looked after very well.
Could I ask a quick question just on that? Sorry to interrupt, by the way. So you're talking about page 87, aren't you? It might not be the same thing. We can't, because it's black and white. We can't see which is 2023 and which is 2024. Do you know? Have you got in colour there?
the top line on the demand is this year. So that's obviously demonstrates the increase. The bottom line is 2023, January to June. And then the next one along, the top line is the Portsmouth area in terms of Category 1 and 2 calls. The bottom line is the rest of SCAS.
Sorry to interrupt, and
No
if
problem.
you want to carry on. Do.
Thank you. In terms of overall performance, performance does continue to be difficult across the ambulance sector nationally and equally in SCAS, impacted by a number of things. And we've currently got significant focus on clearly Category 1, our most poorly patients. However, they are a small group of patients. Category 2 is our biggest group of patients. And the current national target is set at 30 minutes. We are, as you can see there, year to date, 32 minutes, but we're running around 30 minutes day to day at the moment, but it does fluctuate. We know we've got some work to do there. Just in terms of broader pressure, the ambulance sector nationally works at REAP, to a REAP framework, with 4 being the most extreme pressure. SCAS operated at REAP 4 through the winter months and currently are operating at REAP 3, so still under severe pressure. Again, that's not unique to SCAS, unfortunately, and this is reviewed weekly. In terms of transformation, we have a new transformation team now, which is executive-led around making SCAS fit for the future, and that has a number of different work streams around making sure we're more efficient, more effective, reviewing our deployment models, reviewing our resourcing, both people and estates and vehicles. So it's a massive piece of work that will be going on over the next number of years, but there is a programme in place with an executive lead that will be continuing with that. And just on that one, our North Harbour base, which is our base that covers Portsmouth and South East Hampshire, is going to be the pilot site for, we're looking at creating hubs where we've got different areas of SCAS working within the hub. So currently at the North Harbour Caution base, it's a frontline 999 operational base. We're looking at a model of bringing perhaps other departments, for example, perhaps HR, perhaps our people who do our scheduling, and other departments within SCAS, so that it operates much more efficiently and things happen quicker, because a lot of what we're doing is waiting for other people to and fro. So the point being more efficient, being more local, having a bigger team SCAS on that site. So North Harbour is the pilot site for that, due to commence in October. So hopefully we'll be able to feed back some positive news from that in the future. Patient care, I've spoken about the primary piece there around the PSERF and making sure that we're learning, but we do continue to work on our pathways and information sharing across partners to make that as best as possible. In terms of hospital delays, again, I know this comes back a lot, but it is a big impact on SCAS. You can see, obviously you can't then see the colours. So within each month, the first bar is last year and the second bar is this year in terms of ambulance delays.
Yeah, some members have got it online. They're very techie. Some members have got it in colour, and some members like me have got it in black and white. So I'm probably the yeah.
You can clearly see the challenge with that, and since last year, actually, that challenge has grown somewhat. I did take an action from the previous hospital around what does that mean in terms of lost hours, and as noted there, that was an example week. I took 15% of our resources were unavailable because, and that I would suggest was a good week. So those resources are not available to respond to the next patient. This obviously impacts on our Category 1 and 2 performance as well. And in terms of improvement plan, the SCAS improvement plan continues. We are expecting CQC to revisit us, and part of the improvements was from previous CQC inspection, amongst other areas of improvement that clearly needed to happen. So we are expecting CQC to revisit, but you can see there that we are under those headings, continuing with our improvement plans, including financial recovery, which is a challenge, I think, for everybody at the moment. I think that's it, if that's okay.
Thank you very much, Tracy. So over to members. Do you have any questions or comments? Councillor Raffaelli.
Thanks, Tracy. Good to see you again. If I may say, SCAS actually do incredibly well, and you can hold yourself against other areas, but you're under immense pressure. The bit I'm particularly interested in is the one you were talking about laterally there, about the delayed transfers in the hospital setting. Two questions. One, for the future, do you think the new emergency department at QA in due course will ease things there? That's a guess for the future, we're all hopeful, a guess of. But you do say there are a number of actions in train. Now, we have heard this before, and as you say, it's still getting worse. What are the actions, and is there any part of the team or the various inputters who are not being as proactive as you would like to try and redress? Because it's clearly bad for you, it's clearly for the next patients, but it's also not right for the patients who are stuck with your people waiting to get into some kind of hospital setting. Thank you.
Thank you. I think you'll be aware, because we've had these, you always have questions for me, you'll be aware we've had these conversations before, that a number of things have been tried over the years, over many years, in terms of hospital delays at QA, because it has been a long-standing problem. The current position is that we're working on some triggers to get to the point where. Sorry, let me get my words straight. We're working on some triggers so that we don't get to the point of a queue in the first place, which it seems fairly common sense, but what we've done previously, I think, is we've reacted to a queue rather than tried to prevent. So there's work going on to try and prevent the queue in the first place. There's work going on to look at whether there's a way to better distribute the patients across Hampshire. Very early days with work on that as well. There is now an oversight board which is Chief Exec led, looking particularly at the Portsmouth challenges and the Portsmouth Hospital challenges. And the ICB lead now for UEC is the SCAS Chief Executive, which has not been the case ever before. It's never been a SCAS lead in that position as exec lead for that work stream. So all of those things I think are positive for us to be able to influence what else is going on. In terms of I don't think there's anybody who doesn't want this to go away. I don't think there's anybody who's not fully supportive of making this position better. Will the new ED make a difference? We're hoping so, but we know it's not an ED problem. It's a system problem.
Okay, I've got Councillor Owen Jackson. Is it a follow-up on this particular issue? Okay.
So I think I start from the basis that we are very heavy users of your service at the moment, and I have to start by saying I am amazed at the professionalism, courtesy and quality of the staff who work with you. They have been absolutely unbelievably good, and I'm incredibly grateful to the many members of the ambulance service who we seem to have seen. It has not always been easy, so we had a 14-hour wait once to get to A&E. But I hope the new emergency department works, having been in wards where you look down on it. I think the biggest count I had was 22 ambulances waiting outside A&E, but having spent many hours in A&E, it strikes me that there are people who are in A&E who probably don't need to be there. And we concentrate, it seems to be, a lot on trying to get people out of QA. If we could reduce the numbers going in to QA through the emergency route, it would make life a lot easier. And I've just wondered whether there are changes that could be made so that your staff were empowered to make some decisions in terms of risk assessments, to say to people, actually, probably you don't need to go. And I'm particularly thinking of people coming from nursing homes and care homes, or people where they've had an out-of-hours doctor come in, and where just watching them in A&E, it would feel as if those professionals have kind of wanted somebody else to say, yes, it's all right, and therefore they send people into A&E and clog the system up. Are there additional powers that your staff could have to risk assess patients, particularly coming from care homes and nursing homes, to say, actually, no, they don't need to go to A&E. Actually, they're okay to stay here and we don't need to clog A&E up?
Thank you. So in this area, the SCAS clinicians will leave around 51% of patients at home. They will do an assessment, they will do exactly as you've described for over half the patients they go out to. So yes, they are empowered to do that. There is, for our junior clinicians, there is a validation line where they can check with a senior clinician within SCAS. There's also opportunity to contact primary care, to contact community teams. So we have a really, really big focus on non-conveyance, partly because of the issue, but actually most of the time those patients don't need to be in ED, especially elderly, frail patients. We've got a good relationship with the older people's SDEC now in QA, where we can take the patient directly there without going to ED. So they don't sit in ED, they go right straight to the specialty, and there are other specialties that we use as well within the hospital. So there are processes to do that. There will be patients that slip through some of that for patient safety reasons, I suspect.
Yes, did you have a follow-up on this one?
Yeah, well, just a piece of feedback I had from residents a while ago, just to say that they had on their road, somebody who's clearly had a significant alcohol problem, who had ambulances there every day, and sometimes more than once a day, and where the patient was unwilling to be treated and didn't want anything, and yet the need was there to visit. Is that an enormous pressure on your time to go to people, continuous callers in, but actually where they don't want a service and they resist a service?
The short answer is yes, there are a number of those people in the community. Quite often it's not the patient themselves that calls, it's a passerby or a relative, and then we have a duty of care to respond either by giving telephone advice or by attending. We do have a complex care team who look at our frequent callers and then liaise with that person's GP. Not always easy because some of those folk don't have a GP. So there are probably a group of patients that are quite difficult to manage, but we need to do something.
Councillor Tyndall on this issue, is it?
Yeah. So I was going to, looking at the sort of the data and the hours, I'm assuming it was that there's no beds at the QA to hand over, but you alluded to that possibly it might not be just the beds, it might be systems. Is that the case?
Yeah, so in terms when I say system, I mean there are no beds. That's quite correct. But part of that is because it's difficult to discharge some patients because community beds are low, and part of that is some of the things Andy described, I think, around care homes. So as in a system-wide issue rather than an ED issue.
Do you have a follow-up on that at all? To anyone else on that issue? Councillor Williams.
Thank you, and please do cut me off if this has been covered at a previous meeting. My question was in around the impact of potential, so I represent the Winchester City Council area, but the southern area of the district, the potential impact of those migrating to QA should the Winchester Emergency Department be downgraded to an urgent treatment centre. I was just wondering if the impacts of that have been covered really, or assessed. I know the consultation is closed, but if that could be sort of covered at all?
I don't have the detail because a colleague of mine has sat for many months on the Modernising Our Hampshire Hospitals programme, which I'm sure you're aware of, and there has been some quite significant modelling around where patients will go should wherever the site is chosen, etc. But as I say, I don't have the detail, but there would potentially be an impact.
Are there any more comments on this particular issue about Winchester, the catchment area? No? I've got Councillor Heaney. Do you have a question?
Yeah, I was struck by the tables on page 87, particularly the two at the top, the graphs about SCAS-SE demand. And what struck me was, obviously the figures are higher in 24 than 23, but what was interesting was that the pattern of demand is almost exact. And I was thinking, what's going on in March and what's going on in May that produces sudden peaks? And I wonder if that is just a peculiarity of this year, or whether that's something that's happened
Bank holidays
before. Well, I honestly don't know. I mean, it like, really struck me as I looked at it. I thought, gosh, that's almost exact. Why is that? And so I don't know whether we do know an answer, whether that's a pattern that has just emerged this year, or whether it's happened before. I don't know whether you have any views on that.
I don't specifically. I do know that if you looked over years that there is a trend, but specifically March, not sure.
And my other observation was on the higher acuity. I'm assuming that if we were to roll back into the latter part of 23, that the rise in higher acuity demand starts around about November, December, and into January, and then falls away, and then continues with that. That's the sort of way, because people become, or gradually become iller in the winter. So I'm assuming that's the pattern we would see. Is that right?
It is broadly, although this last week we were back above 60%, so it fluctuates week on week, but there is a seasonal trend more broadly.
I suppose the reason for asking that question was looking for, is there anything that we can identify that we could possibly do something about to try and ease the demand? I don't know, because obviously I don't need it, but it just struck me. But obviously this issue about demand is multifaceted. There's lots of reasons why people have demand, and it may not be simple just saying, oh, there's a peak there, can we identify the peak and squash it or whatever. So yeah, thank you.
Councillor Harris.
Thank you. Sorry, I'm new to the panel, so this might be a fairly obvious question. I just wondered if there are any other vehicles, such as bicycles or people or responders in cars, as well as the ambulances, who respond to people who are of lesser interest, of lesser severity. Do we have those sorts of services? Thank you.
Thank you. We do. We have our specialist practitioners who are in cars. They have enhanced clinical skills, in particular for minor injury and illness. So we actually focus those on the lower acuity patients, because they can, broadly speaking, deal with them at home. So we do have specialists that do that. No.
Thank you. Are there any more questions from members at all? No? Okay. So thank you, Tracy. Thanks for your report and answering the questions. Welcome to stay. Oh, we should say that the report's noted for the minutes, and you're welcome to stay if you want to, but equally if you want to go, we understand why. Thank you. Okay, so the next item agenda is item number 7, public health update from Matt Gummerson. So Matt, hello there, hi. Could you give us a brief summary of your report? We have read the papers, and then members will ask any questions. Thank you.
Thank you, Chair, and apologies from Helen Axon, Director of Public Health, who's on annual leave, so couldn't be with you today. So the report just provides an overview of the activity led and commissioned by the Public Health team over the last 6 months. It covers the whole range of public health activity, from our work with partners, including health and within the council, on issues like greening and health protection and climate change, the intelligence and research work that supports decision making across the system. And because it's my area of work, I particularly draw your attention to page 6 of the report, which explains our new joint strategic needs assessment pages, which are updated with lots and lots of information about health and care in Portsmouth, if you want to while away a few hours looking at the data. Also covers the areas that we lead on or commission around things like sexual health, healthy weight, substance misuse, etc. And also the ways in which we try and promote ways of working, such as community champions working within our more deprived areas. Happy to take questions on anything covered within it.
Thank you, Matt. So over to members. Do you have any questions? I know we've all read the report. Any questions, members? Councillor Heaney?
Just have one question about the data, because it was around the physical activity, particularly it talks adults 16 plus and also to an extent children. And it says at the bottom, and it doesn't have a page number, so I can't really be sure which one it says, adults physical activity 16 plus year olds. Trend data and active 150 minutes reading. At the bottom it says, the caveat, data is small scale, 500 per year, hence yearly variation is also self-reporting, not generalisable. So this is a small sample of people, so it's quite difficult to work it out. Because when I was thinking about children, we often think about children not being active. But I was thinking, do we measure children's activity at school where they have organised activity? Because very often you'll see children out in the parks doing lots of running around and doing stuff which probably doesn't get recorded. You know, I mean, I live opposite a park, so I obviously see that. So they are being more active, and I'm wondering if we're actually capturing exactly the sort of level that they are actually at. So two questions really. One is about the data and one is about children.
Yes, on the children's one, it is self-reported again, but it is asking about their levels of activity, so it includes everything, and the survey explains the types of activity that you might want to consider. So it does include, let's say, general running about as well as organised activities within schools. The adults one, it's the Active Lives survey, so it's a national survey, and then they model the data for local areas based on the responses they had in our population profile. So the numbers of actual participants from Portsmouth in that survey are relatively small. It's a sufficiently large sample nationally for them to have statistically significant results, but that means that the Portsmouth population that are in that is relatively small. So yeah, it's a useful guide, but we wouldn't want to kind of base too much on that.
Thank you. Any other questions from members at all? No. Okay, so thank you, Matt. Sorry you had to stay that long. Really good report, thank you. You're welcome to stay. So we note the report, and if you want to stay, you can, but otherwise, thank you. So the next item is agenda item 8, which is primary care update. So it's James Roach. So hello, James. Sorry to keep you waiting. So James, could you give us a brief summary of your report? We've read the papers, and then members will ask questions. Thank you.
Thank you. So I'm the Director of Primary Care at the ICB. So just giving you an overview in terms of access to primary care. There is a slide in there which just reflects where we are regionally, and I noted some of the concerns recently in this meeting in terms of overall performance of the ICB, and I think it's fair to say, and it's reflected in what we've seen in Portsmouth, there's been significant effort in terms of increasing access for our patients and increasing the range of options by which people can access primary care. I think more appointments is a good thing, but it's not necessarily a measure of success. And I think one of the things we need to look at is making sure that we're providing appropriate care for those patients that need it, but equally we're providing a range of options beyond general practice. And that's a key part of our plan moving forward. Within the report, I reflect the number of appointments in Portsmouth, and I think every practice has worked considerably hard in extending access for their population, given some of the constraints they're under from a workforce perspective, an increasing demand perspective, and where some of them are from a resilience perspective as well. So for the first time, the rate of appointments in Hampshire is not the lowest in Portsmouth is not the lowest in Hampshire and the Isle of Wight, and we're really keen to maintain that and ensure we make sufficient investment to practices to extend access. You'll see with our overview of the capacity and access improvement plan, we have made investment in callback functionality, digital options for patients, and we are working with our patient participation groups to improve our practice websites and also look at how we can extend digital options to our patients moving forward. You may be aware nationally there are concerns over the national contract and the value of that national contract for general practice. That is raising concern for our practices. So we are doing a lot at the moment, looking at how we can bolster resilience of general practice on an individual basis, but also how we can connect our practices so they work better at scale. They work in partnership with other providers. And I think there's a really strong base of integrated work in Portsmouth, and we're really keen to sort of harness that through the development of integrated neighbourhood teams, which I'll touch on in a second. There is data in the pack around the Pharmacy First programme. 100% of community pharmacists in Portsmouth are signed up to the scheme, and that's contributed to Hampshire and Isle of Wight having the highest number of consultations through Pharmacy First in the region as well. So, and I know the local authority have done a lot in terms of directing the pharmacy strategy and engaging with our population around pharmacy as a route of access. So thank you for that. And that's something that we're keen to build on. Just a couple of things for development moving forward. We know we've got to sort of change the way we communicate with our population, and there's been a really good initiative in Portsmouth called It Takes a Team, and we want to extend that sort of takes a team approach to the rest of our population. There's been a recent patient satisfaction survey, and there has been some improvement in Portsmouth, and I will share the detail of that on a practice level with this committee. And just the other point, though, I just wanted to finish with is we are putting a lot of work in our partnership with health and social care, with other providers in the health space, and we are looking to expand the concept of integrated neighbourhood working. And I think that's a really important point to make in terms of how can we become more proactive in the way we provide care, less reactive, and look at how we can prevent need moving forward. I noted the comments earlier about the number of people transferring to long-term residential care. Are there more things we can do from a health perspective downstream to prevent that and work in partnership with our partners to provide a more sort of clear pathway for continuity? So that's the update. I think lots of good progress in terms of access, but lots to do in terms of sustaining that.
Thank you, James. So over to members. Do you have any questions? Councillor Vernon Jackson.
Thanks. It's an interesting report. I am struck by a statistic on our page 123 that says the number of people who had an appointment on the same day was just under 50%, and that just doesn't strike me from anecdotal evidence as what I've seen. I've sat in reception of GPs at 8 o'clock in the morning watching the queue come in, and by 10 past 8 every appointment is filled, and anybody who comes in at 12 minutes past 8 doesn't get an appointment. I've been to my GP surgery to try to get an appointment, and 2 weeks was the earliest available. So, but I have had on the day things where it's been online, and that works brilliantly for me. Yeah. I think it's a great service, but it doesn't work for everybody. It would be really helpful to have this broken down in terms of the appointments. Are they face-to-face, are they online, or whatever? And there's some other stuff here that's useful, but quite a lot of the stats are not at a Portsmouth level, and there are the things that now I have written them down somewhere. The bits that I think I would want to know about primary care is the proportion of people in the city who have no GP, the proportion of the appointments that are face-to-face, and the percentage of the appointments who are not with a GP but somebody else, because I think that's it's not a bad thing if somebody is seeing a diabetic nurse, because actually the diabetic nurse often knows way more than the GP, and therefore, but I think it would be useful. I'd also want to have an idea of the number of people who move GPs within the city, because I think that's a useful indicator of how unhappy people are. And the thing that people have said repeatedly is we can't recruit enough GPs and they're retiring early. And it'd be useful to know the number of GPs in the city by full-time equivalents, just to track where we are, whether it's going up and down or whatever. Finally, the bit I have to say, the Portsmouth Primary Care Alliance is absolutely wonderful. Absolutely first-rate out-of-hours service. I've been really, really impressed with them. And if we could replicate what they do with other bits of the system, that would be brilliant.
Thank you. Did you want to reply back, or do you want it in the next report? Or?
Just very briefly, I think we've got a more detailed data system now, which allows us to track number of appointments by healthcare professionals. So happy to share that. That'll give you an indication of what we're doing in terms of our workforce. And you're right in that some patients will be seen face-to-face, some will be seen virtually, some will merely have their needs addressed in a non-facing way. It might be a repeat prescription, it might be a referral to another service, so we'll try and break that down.
That'd be great.
provide
Did you,
that.
did you have a follow-up,
Well,
Councillor?
only just to say, the last two things, hypertension and contraception services, it's quite nice to see us versus Sussex, but actually Hampshire and Isle of Wight is a very, very big area with very different bits, and what might happen in Alresford with contraception may be very different than Portsmouth. And is it possible to break this down to the bit that we're meant to be doing?
Yeah, it's less straightforward than breaking down general practice appointments, but there is access to data through NHS Business Services Authority, so we will look at that, and we have asked for that local breakdown as well. So it may be useful to provide a briefing in a quarter with everything broken down on the local level, just to give you that level of detail and assurance.
And it might be Portsmouth, a slightly wider area.
Yeah, that would be
Gosport, Fareham, Havant, or
Yeah.
whatever. Yeah.
Yeah, so we'd like that. Thank you. Councillor Harris.
That leads a bit nicely into my question, because I was going to ask about the Pharmacy First programme, and it's 100% of community pharmacies in Portsmouth have signed up. But do you know how many pharmacies in haven't? And I wonder whether a colleague in Winchester would want to know. Are you able to provide any data? And in the subsequent things, as the councillor said, are there any statistics for the haven't area? Thank you. Thank you.
So that's something in the in a previous year that we actually, it was people from Portsmouth saying that we thought that there should be data provided for other areas. So I'm really pleased that you've mentioned that.
I assume I'm on this panel for a reason. So, thank you.
Would that be possible as well?
Yeah.
Yeah, thank you. Councillor Tyndall.
Yeah, just to really follow on about the data and about sort of from my area and about how can we break it down to the poor performing practices in Portsmouth. I know it's going into really micro detail, but do we have access to that to see what we can do as a council to go, right, well, we know that that practice is underperforming, just for instance the wait times or the appointment times, what can we then do about that?
It feels, Chair, like we almost need a report to come back which provides more detail on practice by practice, locality by locality, but actually would be helpful to contextually inform some of your considerations. And I think I see that as an opportunity, actually, so you can see the pressure general practice are under, why we're making the decisions we're making, and why your support's so important. So if you could give us a month or two to do that, I think there would be value in bringing a more detailed presentation in live form to this committee, which shows you
Tomorrow
the drawdown.
would be good.
Well, yeah, but I think it's an opportunity.
It would be
for
really
us.
good. I know members. We've sort of talked about that before, and it would be really sort of thing we want as members. So yes, please. Yeah. Councillor Heaney.
Just a comment, actually. You said in your introduction that there's been increasing appointments, which is obviously interesting, but you said that wasn't necessarily a good thing. But I assumed when I saw the figures that these figures are for GP practices, and that would include appointments from GPs, practice nurses, physician associates, whatever. So actually, the increase in appointments might mean that people are going to more appropriate people, i.e. not necessarily going to the GP, but more work going to practice nurses or whatever, which actually would be a good thing. So that means the increase in appointments is actually being more effective. Because the other thing, it seems to me, is that sometimes, if it's not an emergency, sometimes it can take a couple of appointments to actually work out what the problem is. You come and you try something and it doesn't work, so you go back again. And again, anecdotally, my own experience is that if you come and talk to the practice and you want an appointment, they will seek to find ways of getting you in early. If it's not an emergency, but something that's troubling someone, they will actually work quite hard to find a way around the system to get you something reasonably quickly, not having to wait 2 weeks saying sorry, that's it. So I think the practices do quite well. Obviously, where they don't, we probably need to ask why. But I'm on the positive side from what I've seen and heard anyway, that they've done a really good job under huge pressure, of course.
Yeah, and there's two elements to that. One is we've got to make sure that we're freeing up GPs to deal with the most complex in practice on the day to avoid that referral to hospital. So that requires the whole team. And then the second thing is for those that have long-term conditions or a level of need, we need to provide continuity of care outside of hospital. So you start to break it down. Tactically, you work out how you stream patients and how you manage it. But all the additional investment that's gone into primary care networks has meant that a patient can see a pharmacist, a nurse, a social prescriber, a GP and a physician's associate. By increasing choice, we're changing the way people access services. And I think longer term, that's a good thing.
Okay, I don't think there are any more members' questions. So thank you very much. Sorry you had to wait a while, and you're welcome to stay.
I've got to stay for dentistry, so
Oh, there we go. Okay, all right. So thank you, James. So that report is noted, and it would be great if you could bring those figures to the next meeting or meeting after that. So the next thing is agenda item 9, dentistry. So we've got Simon Cooper. So Simon, we've read the report. Could you give us a brief summary, and then members will ask you questions? And sorry that you've had to wait.
That's fine, Chair. What I will do, and I've done this in similar committees across Hampshire and Isle of Wight, is I'll touch on some of the parts within the report to bring out some of the nuance and the geography that is commissioning dentistry that might not be immediately obvious. So first off is registration with an NHS dentist. You do not actually register with an NHS dentist. There is no compulsion for an NHS dentist to see you beyond a course of treatment. I will regularly get letters from the public saying that their dentist has deregistered them, and I have the slightly demoralising task to explain to them that they were never registered in the first place. There is no compulsion, there's nothing I can do within the contract, I have no levers to actually comply with that dentist to actually comply with a registration which was never there in the first place, which is incredibly frustrating. It's a completely different situation to where you are with a GP, which we are so up to speed with. The course of treatment is very key within the contract, and you'll notice in there we talk about UDA, so it's a unit of dental activity, which is a tariff by which we reimburse dentists for. So the tariff goes through the various bands, but the dentists are reimbursed dependent upon the highest band that patient reaches for a course of treatment. So how that actually works out in practice is if you attend for a checkup and the dentist says we need to do a couple of fillings, then we also need to do some complex work within a bridge, etc. So they work up to what might be a quite high band 3, for example. That dentist is then only reimbursed for that top band. So it's a bit like going to your mechanic and saying, I want a service on my car, please, and the mechanic says you need a couple of tyres replacing and your gearbox replacing, and you saying to the mechanic, I'll only pay for the gearbox because that's the most expensive bit. That's how it's set out. The other thing around the UDAs is that there is no set fee for a UDA. It is different for every contract. So we will have contractors within Portsmouth within perhaps a few hundred yards of each other being paid a different rate for providing the same service for the same population. So there are some puzzled looks around the room. Welcome to my world, I would say. So they're the challenges in terms of that. Despite all of the things in there, the biggest challenge that we do have is around workforce. And is getting the number of dentists in the NHS that will allow us to actually provide the services. And one of the other lids that I took off a can of worms when I first took this on is that when you qualify as a dentist and you finish your degree, the following day you can work in a private sector. Should you wish to work in the NHS, you will have to do another foundation year before you can work in the NHS. So we can see that there are some I can see some shakes of heads around the room now. There are some challenges in that. Now, despite that, we've got what I think within the ICB pod team, a team that is punching well above their weight, and we are seeing increasing numbers of people within Portsmouth accessing dentistry. I said several months ago, about 18 months ago, when I attended a public meeting within the ICB, it's not in my gift to throw a switch and make dentistry better. The first thing I have to do is stop it getting worse. Then I need to stabilise it, and then we can start to make it better. I think what we are starting to see is that stabilisation has happened. The improvement in the number of patients seeing dentists is small at the minute, but it is continual and it is increasing month on month. So I'm hopeful what we're seeing in Portsmouth particularly is
are slowly increasing that access for patients for dentistry. We are nowhere near out of the woods, and I wouldn't suggest they're very much beyond stabilising the system, but we are starting to see an improvement.
Thank you. Just on, I think you're page 9, so it's our page 139. Would we be able to have the breakdown for, so it is useful seeing other counties and stuff, but would we be able to have, this is to access to NHS dental services, would we be able to have a breakdown for the Portsmouth, this Scrutiny area, so Portsmouth and the other surrounding areas? Would that be possible? Is it possible?
Yes, but it can be challenging to get that information. So the current access to dental information that we have is based on the number of UDAs that are provided. There isn't a quick relationship between UDAs and patients, and that data is provided by contractor. Now we know that residents will travel considerable distance to actually access the dentist currently, and as an example of that, I could, if I had a magic wand and put a large dentist in the most deprived area that I could find within Portsmouth with the greatest need, with the data that we currently access, I couldn't tell you whether that solves the problem or whether that could be people coming from the Isle of Wight, Southampton, Winchestershire, etc. So what we need to do is to cut it in two ways. Is one, to look at our contractors and see how they're performing, but also get from the BSA that have that data, because we can't see the patient level data, is to look at Portsmouth residents and seeing where they're going for in terms of contracts. So yes, we can, and we are pushing for better granular access to the data, but it's not immediately available to us.
Okay, thank you.
Long answer, sorry.
Yeah, I don't quite get the end of that, if you see what I'm saying. So is it possible or isn't it possible? That's the...
So it would have to come through a different route to the one that is coming through. It would have to be specific request and regular specific requests for us to get that from the BSA to see where the residents are, because it is not the normal data set that we see.
Okay, thank you. Councillor Vernon Jackson.
BSA is a motorbike to me. What is BSA?
Business Services Authority, the NHS. So they hold a lot of the data centrally around commissioned services such as dentistry, optometry and pharmacy.
Okay, lovely. Thank you. Simon, on our page 136, which is be a different page to you, in paragraph 4, it says, means that many practices do not fulfil their contract in full, and in Portsmouth has a delivery rate of 38.3%.
It's your page 6, I think.
Yeah.
So does that mean that only 38% of the UDAs that are available in Portsmouth are being used?
Yes.
That's terrifying.
Yes.
That's probably the most shocking things in the entire papers we've had today. So that over 60% of the available NHS appointments in the city aren't being used when people are crying out to get NHS dental appointments.
Yes, and the reason for that is you contract on a number of UDAs.
Yeah.
So that contract then stays in perpetuity. If that contractor then struggles for workforce, they then cannot fulfil the number of UDAs they're contracted for, and we then subsequently claw back any payments for which they didn't have.
And you then, when you've clawed that payment back, you then redistribute the money to somebody else who then might be able to do the work.
So that then comes back to us to do things like we did with the Dentate bus, for example, in terms of that. So we will use those funds. So it's worth noting that the dental budget is ring-fenced to stay within dentistry. So we will use that within dentistry, but there is a continual catch-up process in terms of that clawback. Yes.
James, did you just want to add
just as a follow-up, I mean, you'll know we're dealing with quite a difficult market in terms of what is motivating them in terms of their business models. So one thing we've done, and we haven't articulated in the paper, is we're starting to engage with these practices as individual businesses to understand what support they need to see more NHS patients, what assurances do they need. Often it's not just about investment, it might be access to training, education, support from other dental practices. So the new contract gives us an opportunity to engage directly with these practices as individual businesses to see how we can encourage them to support more NHS patients as part of their practice delivery. So we are having those conversations. It will take time, but we are seeking to create a new form of engagement with that business model.
Okay. That's very helpful, but that is a truly terrifying statistic you have there. I'm sorry, Chair. I have another meeting at 7, and it has just struck, so I have to be elsewhere in the city, so my apologies. Finally, I do find some of these acronyms difficult. For those of us who worked in Northern Ireland during the Troubles, UDA has a very, very, very different meaning to things about dentistry, and significantly more painful. But so thank you very much.
Thank you.
Thank you. So I've got next Councillor Heaney, and then.
Yeah, I also highlighted that paragraph when I read the report and thought, oh gosh, but what was interesting was comparing Southampton, where the situation seems to be markedly different. Their fulfilment of the contract is much larger. So what is different in Southampton that is allowing more dental appointments to be done than there is in Portsmouth? Because we're similar cities in many ways, although we have our differences over certain things, but you know, what's going on there that's different? Why is it so different in two?
You mean in terms of the completion of the UDO?
Yeah, what's going on there?
So a lot of that is historic, and some practices will just continue to regularly function at a level that they can carry on. So as an ongoing business, they can still function providing 30% of the UDAs. What we are looking to do is looking to go to those providers and rebase that contract that we can now do, because obviously that in a hypothetical practice that is providing only 30% of their UDAs and continues to only prescribe 30% of their UDAs, it isn't a transitional problem or a workforce issue. They are tying up 70% of that activity that we could potentially use elsewhere. So we're starting to engage, as James said, we're starting to engage with some of those practices to say, where do you expect to be? What is the future for you as a practice? Are you going to carry on at this level for the foreseeable future? And can we start to vary that contract to release those UDAs so we can actually start to either commission new dentists or look at the dentists who are high providers up in the 90 and 100% provision and effectively recycle those UDAs into those other practices that are higher performing and potentially have a way of pulling in a workforce that others can't.
Councillor Heaney?
I sort of follow up. My point really was, why is Southampton doing better than we are? What's the difference there between the completion of a contract, 54.3% there, but only 30? What's different? Why are they doing better? Do you know?
There isn't a specific reason. It's down to individual contractors and the historic level of that contract.
I mean, I won't bother you now, but I just find the whole thing completely bizarre. The more I learn about dentistry, the more I think whoever on earth thought up this system, and presumably before 2006, were you registered with the dentist? Because I remember being with the school dental service when I was a kid, and then I went to my parents' dentist. You know, so was there ever a registration thing for dentist or not? I'm not going to bore you with lots of detailed questions about that, but I just wanted to get a sense of the perspective.
It's not something. I was going to say I'm not that old, but I probably am. It's not something I'm aware of. And just going back to your previous point, I think anybody that starts to work in dentistry like we've done in the last 2 years would agree with your bizarre comment. It is sometimes challenging to understand where it is, or why it is as it is, and why, with my predecessor Joe York, we were invited to the Health Select Committee at the Houses of Parliament to feed back on some of these things, and we would very much welcome that contract reform to give us perhaps a different way of doing things.
Okay, thank you. So next I've got Councillor Raffaelli, then Councillor Tyndall.
Simon, thank you, and thank you for being so frank, brutally frank. In fact, you've opened the door to almost a nightmare scenario. I had not realised just how dystopian the whole arrangement is. You're clearly making lots of effort in the local area to try and resolve it, but your hands are tied. do you have much hope that central government will try and rejig this whole thing? Otherwise, you're just going to be moving chairs, frankly, it looks like, would be my first point.
I mean, that's the hope with the new government. They have pledged to look at the dental contract, and we've been very clear through NHS England that we need reform, we need more flexibility, and we need autonomy to deliver our financial envelope for the benefit of our patients. So we're hoping, fingers crossed, in the next 6 months there'll be a bit more clarity on it. As usual, where does it sit in the myriad of political priorities for the Health Minister?
My question then is, let's all hope that happens, but are you confident that the dental professionals, businesses, are actually on side for that kind of reform? What are they looking for?
So yeah, I will just address that. So one of the first things that we did when we took on the delegated commissioning was we had something called Dentistry, the Big Discussion, and we invited all the stakeholders that we could get, from practices to NHS England to the LDC, etc. And my lasting memory of leaving that day was that the dental professionals that were there were very much invested in the NHS way of working. They wanted to work with the NHS and were supportive of it going forward. But their view was that the contract needs reform as well. And that is the challenging thing in terms of bringing in more dentists into the NHS way of working, is that contractual reform. So I think if we get that piece right, there is a workforce out there that would come into the NHS, yes.
Yeah, that's quite encouraging. The bit about registration, flummoxed completely. I've just looked on the website, NHS website, saying how do I register with an NHS dentist? And it says what we've all heard and all told our constituents and residents, you wait till a dentist says, I'm now taking on NHS patients. I got taken on by an NHS dentist, and they keep in contact with me all the time. They call me, my wife, my family up. I get what you're saying. Technically, it's not registration, but once you're in the fold, but it doesn't help when the NHS website are using the words that you're saying don't exist or apply.
So yes, I completely agree with you. What actually happens in the pragmatic context is that it makes good business sense for a dentist to have we could call it a regular calls list. So they will regularly call you in to bring you in. But as I said, within the contract, there's no compulsion for that, and there is no register. In the same way as a GP practice, if a GP was to hand back their contract, we would have to find homes for those patients and distribute those patients, or potentially find a new practice or whatever. Within dentistry, there is no compulsion for that.
Terrifying, but thank you. Can I ask one very specific question about Gosport? On our page 134, which is in your onward referral services, about orthodontics, it says across all areas other than Gosport. I'm Gosport, why?
A good question, and not one I could answer as I sit here now as to why there isn't orthodontist within Gosport. I would suggest perhaps at the minute our focus is on general dental services, but I don't think orthodontics will be very far away, because there is a need for those as well. Why there isn't specifically one in Gosport, I couldn't tell you.
Happy to come back on that point.
Yeah.
Can you just put your microphone?
Sorry, happy to come back on that point. Clearly a concern for you and will be for your residents as well. But there is a strategy around orthodontics, and we are looking at a range of different providers, but I think we'll try and come back on that point. Prior to us taking responsibility for dentistry, it was commissioned by NHS England, so there may be some track back with them in terms of historic commissioning decisions.
Okay, thank you. Councillor Tyndall.
Yeah, it was just to pick up on the registration. I was going to bring up that point. But so I get residents come back to me and say, oh, they're full, but then the data says that they're only fulfilling, what, just above 30% of their hours. Is there any way we can kick back into those dentists?
So what they mean by they are full is that they don't have sufficient workforce to do any more. So in order to pick that up, they need to get the next dentist in, bring in another associate dentist to actually provide that work, and that's why I'm saying one of our biggest challenges is that workforce. There is nothing that within the contract that I can do that would actually force them in however way we would want to word that, to take on more of those UDAs because they don't have the workforce. So the tool that I have is to reclaim those funds by clawback.
So, sorry, follow up. So I take it reclaiming those UDA back is not a quick thing, and there's a big lag on that. So why are we giving out big contracts or lots of UDAs to certain practices when we know they're not going to fill it?
So for the new contracts that we're issuing, we go through a very detailed procurement process that actually assures us that the new contracts that we're taking on are actually being fulfilled or able to be fulfilled, and there's a process within that. What you're seeing, I suggest, is some of those older contracts where they've been through that process but have actually been hit by the workforce, potentially through COVID or retirements, etc., that they're now unable to recruit within that. That's why there's that lag currently in there.
Last question then, to follow up to that.
Can I just, Councillor, I think James was going to say something related to the question that you asked, so sorry to interrupt.
Yeah, sorry. Your first point in terms of workforce, I mean, Simon made a point around workforce. I think reason to be positive, in partnership with the University of Portsmouth, we are looking at a revamped dental academy. And I think there is a message there, isn't there? We've got to create an environment where we can develop our own, to stay in the NHS. Linked to that, there are levers in the contract where you can offer golden hellos, you can support people with relocation, and we can support practices with their own recruitment campaigns as well. But I think we've got to put stakes in the ground for the future now, because we can't operate and rely on the market as it currently stands. We have to shape the market differently moving forward, and that's an opportunity, but it will take time.
Thank you. That was going to be one of my questions about linking with the University of Portsmouth. But going back to the contracts with the UDAs, is there any performance targets in those new contracts? I appreciate maybe historically there's not.
There are effectively no performance contracts. It is solely down to clawback of what's not provided.
Certainly in Gosport and in some other areas I've been involved with, increasingly as the dental surgeons come up to retirement, rather than younger men or women coming through, they get absorbed by the Borg, Smile or whatever, you know, the bigger contractors. Is that making your life easier in terms of providing delivery to residents or not? Having to deal with increasingly the large groups. Are they facing forward in NHS delivery or not more than individuals?
I don't think there's anything specific in terms of the difference from what would be a large corporate provider of dentistry or a small local historic dentist. I think in terms of their forward thinking, it's very much down to the individuals within those organisations. We have good relationships with some large corporates. We have some good relationships with some individual practices. And over the last 18 months, we've had some really good discussions around talking to individuals to understand their view of the situation and how to take it forward. So I don't think I could sit here and say that the large corporate or small individual dentists is the way forward or is a preferred model. I think it depends on the individual.
Thank you. Are there any more member questions? No. So thank you very much for your report and for answering the question so sort of openly. Much appreciated. So we note the report. We've got one item left on the agenda, which is a bit of a legal thing. You're welcome to stay, but equally, if you want to go, you can do. So, okay.
Thank you.
Thank you. So it's the last agenda item 10, and it's HOSP arrangements for accessing substantial change in NHS provision. So this is for noting only. I have to read out this. So the panel are recommended to approve the updated arrangements in line with the legislative changes. Southampton City Council have adopted the updated framework, and the other health scrutiny committees across Hampshire and the Isle of Wight Integrated Care Board, ICB, footprint will adopt the updated framework in due course. Previously, the Secretary of State for Health and Social Care could intervene in reconfigurations of health services upon receiving a local authority referral relating to the adequacy of consultation or whether the proposal was in the interests of the health service in their area. Following a referral, the Secretary of State had a discretionary power to take certain decisions based on the grounds of the referral. Schedule 10A to the NHS Act 26 provides a new call-in power to allow the Secretary of State to intervene in NHS service reconfigurations at any stage where a proposal exists and take or retake any decision that could have been taken by the NHS commissioning body. Instead of the referral power, health overview and scrutiny committees and other interested parties can write to request that the Secretary of State consider calling in a proposal. Such a request will then be considered as set out in the statutory guidance. Last paragraph. It should be noted that local authorities' scrutiny responsibilities for service change, brackets and wider scrutiny responsibilities, have not changed. NHS commissioning bodies' duties to involve and consult the Health Overview and Scrutiny Panel and the public remain in place. It remains the case that NHS commissioning bodies and NHS providers should be actively engaged with their Health Scrutiny Committee from the outset and the duration of a reconfiguration proposal. Now, I've read that out. I'm going to sort of put you on the spot here, Lisa, if you don't mind. Do you want to just explain why this has come? Is that okay?
Yeah, so basically it's just a very minor, this document already existed with the other authorities in the Southampton, Hampshire and Isle of Wight area. This is just to sort of a refresh of the document following the new regulations that came in January of this year, which basically they remove the local authority's power to refer major health service changes to the Secretary of State, but instead we can request that the Secretary of State consider calling in a proposal. So it's just a very sort of minor change, but yeah, the other as I said, Southampton have adopted theirs, and the other two authorities I believe are going to have theirs adopted soon. So it's just sort of a formal process just to so we're all sort of doing the same thing across Hampshire.
Thank you, and sorry for putting you on the spot there. I should have warned you beforehand, but you helpfully told me before the meeting, so thank you. Are there any members' questions on this item? Councillor Raffaelli, yeah.
I think it's a weakening of our authority. Before we could refer it, now we have to request. So I think that's slightly less powerful than it used to be. And the other bit that I think we've been through this before, on paragraph 10 on page 142, it's clear that the responsibility for initiating or identifying these significant changes rests with the local authority, with the Department of Health. The people should bring it to us. There have been occasions, I believe, in the past when something has come up at a meeting or a councillor has been aware that in their area something was going to change that was considered significant. But of their own back, the NHS had decided it wasn't significant, and it required quite a bit of discussion to get them to actually formally agree with this board. I think Lisa remembers a couple of occasions like that, perhaps. I don't think we have any option but to accept this because it's a legal change, but I think it's incredibly important that certainly I've seen tonight, very warm relationships with our partners, as we keep that up, because that's the only way we're going to get them to always come forward with things. And there's so much going on in their life. It just worries me slightly that we're in danger of, we know what we know what we don't know, but we don't know what we don't know. And unless they actually bring it to us and they're responsible, then we might not see it unless we have other reasons brought to our attention. But I don't think we can change anything, Chair.
No, so I feel exactly the same as you. I won't repeat what you've just said because you said it really well. But personally, that's how I feel as well. Councillor Heaney.
Just make a brief comment. I mean, it's always been the case, as far as I understand it, from the beginning, that the issue about what was substantial variation was always open for discussion. There wasn't an absolute, this is this and this is not, because it is to some extent. And then I suppose that then relates to the issue about trust between the NHS and the local authority doing the scrutiny, that one would hope that because there is a duty placed on local authority to consult about health service changes, that they would want to bring things forward that were changes rather than say, oh no, we want to protect this because it's not. I suppose the one issue where I've always wondered to what extent we have influence is if the ICB is looking to change services because of its budget position, to what extent can we influence that? Because if they're saying, well, we're going to make this substantial change because of our budget position, we say, actually, we don't think this is in the best interest of our residents. You know, we might want to ask the Secretary to have a look at it, but, you know, our ability to influence that might be quite limited. But I think it's really useful to have this again, because I think it's quite a long time since I've seen this, and I think it's very useful. And possibly, maybe what we could do when we have our new municipal year is when we have the first meeting that actually that's provided as information for members, because we get new members on, you know, at different times and who may not be aware of that. And I say it's a long time since I've looked at this, so it is useful to have. But I think, as Councillor Alfieri said and Chair said, we'd probably just have to agree this because there's not much point in trying to amend it.
Thank you. So, do I take it that we are going to note this? Do we have to agree it or note it? Yeah, so
Could just be noted with some concerns.
okay, let's do that then. Yeah, I think we've got to agree it, haven't we? So, so shall I propose that we agree it? Thank you.